All right, and we are live. Thank you so much, everybody, first of all, for joining our April webinar. My name is Klaudia, and I will be moderating today's discussion. Our title today is A Game-Changing Approach to Long-Term Care, and as the conversation unfolds, you will understand why is it such an important and timely topic, especially when we're talking national scale. We have a beautiful, brilliant lineup of panelists today, and they have an extensive history in the world of healthcare, and just really, we will be able to untangle various aspects of this topic and subject as we go along. So while we are talking, please feel free to chime into the chat on the sidebar and let us know where you're coming in from, where you're tuning in from. If you have any questions, feel free to drop that in there as well. We will address them as we go, and we will also take some time at the end to address the questions that pop up across the discussion. So let me jump in and do a little bit of a short introduction of our panelists and introduce you to them. So we've got Dr. Sabine von Preyss-Friedman, who is an internist and geriatric medical specialist and has practiced in skilled nursing facilities since her fellowship at the University of Washington. Dr. von Preyss-Friedman currently serves as the president of the Washington State Society of Post-Acute and Long-Term Care Medicine. She's also chief medical officer of Avalon Healthcare. And in these roles, she's truly involved in teaching quality improvement, developing standards and outcome measures in long-term care facilities, and the successful translation of medical evidence into clinical care. Now, her mission is to support the best possible medical care for all long-term patients. Now, up next, we've got Dr. Martin Frasch. He is the founder and CEO of HealthStream Analytics and Vitalink AI. These are the digital health startups aiming to enable smart human and AI-driven biometrics, insights for early warning and prevention of deterioration of health and death in seniors at home and in skilled nursing facilities. Now, Dr. Frasch is an affiliate research faculty member of the Center on Human Development and Disability and the Department of Obstetrics and Gynecology in the School of Medicine at the University of Washington in Seattle. Dr. Frasch's work in physiological monitoring and neuroscience is internationally recognized with about 200 publications and memberships in international research societies such as the American Physiological Society and Society of Neuroscience. He also serves on the editorial boards of multiple top-tier academic journals, such as PLOS Digital Health, PLOS1, Frontiers in Neuroscience, and Frontiers in Physiology. And he's been serving on research grant review panels in physiology and neuroscience for the past 10 years. And it's not only the US, it's Canada, the UK, Sweden, Australia, and New Zealand. And then last but not least, we've got Kevin Longoria. He is an expert in the field of clinical physiology and biometric data science. As the Chief Science Officer here at Biostrap, Kevin has led the development and validation of novel physiological biometrics utilizing raw photophletismography, or in other words, PPG data, and the baseline adjusted early warning system to predict respiratory illness. And he implemented clinical remote physiologic monitoring workflows in various healthcare environments and patient populations, and also contributed to large-scale decentralized clinical trials with pharmaceutical and government organizations, including the National Institute of Minority Health and Health Disparities. Kevin also has significant leadership experience leading a team of healthcare professionals, researchers, and data scientists, and he's also the member of the Scientific Advisory Board for the National Academy of Sports Medicine, the world's largest sports medicine certification organization. Now, thank you so much, all three of you, for joining me and taking time out of your day to be part of this panel and really share your expertise and experience in this world. And as we were promoting this webinar, we highlighted the fact that it's a very timely discussion because COVID-19 has highlighted the vulnerability and medical complexity of patients in post-acute and long-term care. And honestly, long-term care facilities were the first ones to suffer from large-scale outbreaks. And just recently, we had two very important reports that have been recommendations that have come out, one of them being by the National Academy of Sciences. The report is about 600-page long, and it highlights short-term, long-term, intermediate-term implementations of really addressing some of the, I don't want to say limitations, but some of the changes that are necessary in order to provide the quality care that these residents really deserve. And then another relevant topic that's come out in just about a few months ago, Joe Biden's State of the Union highlighted the Biden administration's nursing home reform, which is meant to improve safety and quality of care for the nation's nursing homes. Now, these are various action steps that are necessary to really make sure that residents are safe, the staff is safe, and everybody is given the quality of care that they are meant to receive. So let's dive into the very first question. And as we go along, we're going to be going through the panel in different orders. But I'd like to address the first question to Dr. von Preyss first. And just considering the recent report by the National Academy of Sciences and the President's State of the Union, why now? You've been in this industry for a long time. Why is it now that the pandemic really shed light this need for disrupting long-term care in the US? What is your insight?
Well, it is certainly a double-edged sword if you get mentioned during the presidential State of the Union address. That has never happened to us. We have been rather a stepchild, an area of medicine that most people like to forget about, just like they try to imagine that we never get old and we never die and we never have to go to a nursing home. Yet so many of us and very highly accomplished professionals work in that space. COVID was really a paradigm shift for us. It was a completely unknown disease, and it really started in nursing homes with a highly vulnerable population. And we learned the hard way in nursing homes, not anywhere else, about asymptomatic spread and seemingly rapid deterioration. When I was medical director of the second nursing home in the country that had a COVID outbreak here in Seattle, Washington. And it was just devastating and astonishing, where people started coughing in the morning, seemingly, and by the afternoon, when you finally got them into the ED, they were dead. So I think that was really something that I had never seen before in this way. And I think none of us had ever seen before in this way. Because of that, COVID necessitated intensive monitoring. So I saw a couple of cases like that on March 4th, and I'm like, we got to do something very different here. We can't just, somehow the symptoms have eluded us or for a while, or and then they progress very rapidly. And that was before we really did know how long it takes from infection to symptoms and so on. Mm-hmm. So what we started then was a Q2-hour oxygen saturation check and vital sign check, and that really that intensive monitoring was a huge lift for us, and we really couldn't necessarily consistently provide that. And the other thing about this intensive monitoring in the early days, especially, but still now, was that staff with all that contact incurred a high risk of infection. And as you know, we lost about 2,000 staff members in the US in nursing homes to COVID. And of course, many of them also got ill. And so remote patient monitoring was one of the solutions that presented themselves at the time. And on the other hand, from further down the chain side, as hospitals became overwhelmed with COVID.
Is that my internet, or maybe Sabine cut out for a second?
I'm also seeing.
So you cut out for a second. Okay, I think you're back.
Oh, okay. Sorry,
okay.
That's my internet connections. So we getting more and more ill hospital patients, and these and so these patients are inherently unstable and really need much more medical care, which we can provide. But the detection of the medical symptomatology really is straining the staff. So those were all opportunities. So monitoring by a device is a huge opportunity to get more timely data and free up staff time to respond to the results as opposed to obtaining the data manually.
Thank you so much. This is an excellent point. And you brought up monitoring is such an important aspect to really understanding the course of an illness, and in this case, COVID-19. Now, I would like to turn to Dr. Frasch. What have you seen as an opportunity that really arose with this situation throughout, especially the early times of COVID-19 pandemic, and how did your sort of mission in really developing these AI-assisted technologies really helped?
Yeah, I appreciate the question. As you have seen in the introduction, my experience goes back for a decade or so in a space of the monitoring of the mothers and their babies. And in a perhaps somewhat unexpected way, there's a commonality here that we have seen over the years. Seniors often, as basically Sabine just pointed out, have been ignored in the progress that has happened, perhaps mostly in a space of the sports and the offerings for the athletes and so on. We have not seen as much innovation as we would have liked offer to the pregnant women. But also, and this is where the COVID pandemic really hit us, was that there's so much we can offer to help in a space of the senior healthcare as well. And so, with an expertise and experience that we have in our team to monitor the physiological health and to build the models for the health outcomes, and to also build the software that is essentially using AI to deploy the models. This seemed to be just the right time and an opportunity, a call, if you will, to step in and to seek for similarly minded individuals, entities. And so we've been really excited and thankful to get to work with the folks, the Biostrap and MFIT as well, but most importantly also to work with Avalon, with Sabine in particular, to explore whether what we think is a solution could actually work in the setting. And so we are going to talk about it a bit more, but yeah, it was really call to action where we saw that something needs to be done and we felt that we can help.
Do you think that the fact that the pandemic really escalated staff shortages within the facilities was something that really triggered the understanding that we will need something that's not only human assisted, but also AI driven products that could work hand in hand with individuals to really help understand the course of illness with residents?
It starts always with the humans, and it always goes back to humans, right? AI is a piece in a puzzle that really is a way to facilitate our ability to deal with so many data that we simply are unable to ingest as a human being. But the way we think about AI is that we start with the patients and the providers, and we understand what is the information that we need from a physiological standpoint, from a clinical standpoint. What do we understand in the data? What are we looking for to extract that we already use, but just not at the scale that we're able to do now with RPM as a technology, and then go from there and expand and innovate, iterate, adding AI layers once we build the trust and understanding on top of this.
Brilliant, excellent. Thank you so much. And let me turn to Kevin. Kevin, you played a very important role in Biostrap developing a baseline adjusted early warning system as the pandemic unfolded. How did you see the opportunity with Biostrap playing a role in this pandemic, how to help not only individuals, but really physicians to monitor these patients, and why Biostrap could really provide a solution?
Yeah, I mean, to summarize what my prestigious colleagues have said here, the pandemic really demanded our healthcare system to provide a higher level of care to more people, particularly in long-term care and other underserved communities that were disproportionately affected, seemingly overnight, right? There wasn't a lot of time to plan for this. You combine this with the need to minimize direct contact with these patients, manifestations of things like silent hypoxia, and the need to automate certain processes with technology became very obvious, particularly those that don't require direct clinical decision-making or perhaps clinical expertise, right? The routine vital monitoring, for example. So when we look at technology wearables in general, such as Biostrap, that collect things like oxygen saturation, a very important metric to be monitoring, there with a more convenient form factor, a nice wrist-worn design. The industry has always been ripe for disruption, but I think the COVID pandemic just really escalated it. And when we start talking about, the more longitudinal, more continuous data collection, that there's certain challenges with that, and that's what we're going to dive into in some follow-up questions here. But ultimately allows us to more look at variance as opposed to absolute values, right? This is really one of the powers of longitudinal data, getting away from universal binning and saying 60 to 100 is a normal resting heart rate. It should really be, what is Kevin's normal? What is a normal variance day to day? What is abnormal for me? And this is really how we get towards my favorite part of prevention, which is early detection. I think what has the most immediate impact that technology is well poised to take on.
Okay, that just brings into light the importance of individual baselines and really providing that N=1 approach to healthcare and really adopting that precision medicine in different aspects of healthcare, in this case, long-term care, where everybody's coming with a different medical history and may need different level of care and different type of treatment as we go along, even though they may be battling the very same virus. So thank you so much for these very fantastic insights. I would like to launch a poll because now I'd like to include a little bit of our audience to let us know what you all think. And really the first poll that I would like to ask our audience is, do you or someone you know have a loved one in long-term care? And I'm asking this question because in the next question, we'll be talking about a little bit on the increase of how much of our population will be needing long-term care as our population ages. So let's see, we've got majority of our audiences, yes, they do. I'm gonna leave this poll up for a couple more minutes so everybody can chime in. And while that runs, let me just start off the second question with a statistics, because I think statistics always help us really picture and frame up the conversation. And so according to the US Department of Health and Human Services, right now, there are approximately 8.3 million long-term care facility residents in the US. Now, with the population aging, this number is estimated to double in just 8 years by 2030. So we're gonna have a lot more residents needing just as higher quality care that maybe is provided right now. So let me run through a little different order of addressing the panelists. And Kevin, what do you think it will take to provide new solutions for healthcare delivery? And what are some of the novel approaches available right now, in your opinion?
Yeah, it's a great question, and I think it's really thoughtful consideration of really the patient and provider within the healthcare system, and not just a bunch of software developers and data scientists sitting in a room thinking that they understand clinical workflows and how all of this translates to real world medicine. And frankly, something I'll admit, I think our company made a mistake on early on. We're developing amazing technology and we're really focusing on data integrity, which is excellent. But things like usability are even more important, right? If we can have the most amazing technology in the world, but if we require a one-to-one connected Android or iOS device, we're decreasing the ability for a large portion of our population to have access to this type of data. Or if we have 2 to 3 day battery life, perhaps us researchers are like, great, this is comparable to the equipment that's plugged into the wall all of the time, which 2 to 3 days of contactless is excellent. But when rubber hits the road and you put this on patients' wrists and batteries are dying and charging issues, we're missing data. And this is all extremely important data. As much as I would like to say that wearables are really ready for this mass adoption in the healthcare system and can just go make this huge disruption, there's just significant research, and why I value Martin and Sabine here so much. Research in terms of hardware design, usability, interoperability, specificity for a more comprehensive solution. Now, this is what we are actively working on, but it's not ready yet. Today, even still, and once again, we're trying to address it, remote physiologic monitoring is staring at a screen and trying to make sense of a lot of non-specific data. Martin's an expert in this. You create specificity out of non-specific data by studying it, studying outcomes, and so on. And this is really what I think it'll take for technology to make its way into the mainstream medicine without, just creating more disruption, more headache with it's not a solution if it caused more hassle than it does solution.
I couldn't agree more. That is so true. And Dr. von Preyss, what do you think? What needs to happen in the next 8 years to really meet the need and the requirement to provide the quality care that long-term care residents really will deserve and need in order to live a life that is comfortable?
Well, this is a big question. We can probably have a whole week of webinars to address that. I want to first also acknowledge Ian Taylor and Matthew Weeks's comments. And Matthew, Mr. Weeks, I acknowledge your anxiety about staffing issues and having elderly patients. And I do want to say, though, never in my life have I had more respect for the workers in long-term care facilities than now. These were people, as you said, overall not highly educated, not making a lot of money, and yet having large families to support. And yet they walked in there without N95 masks, with homemade masks, with goggles from Home Depot and rain ponchos for protection to take care of the people in those long-term care facilities that they cherished. So I think that we have huge opportunities, but we also have a lot of dedicated staff, and it's up to us to support that dedicated staff. Going from the physician's perspective, as a passionate physician at the bedside, I don't think anything will ever replace the expertise of a clinician, the empathy, the ability to comfort. And I don't know whether there are any physicians in the audience, but just to let you know that the development and spread of electronic health records have put a tremendous burden on physicians and other clinicians and contribute to burnout of many physicians. We have not yet made the necessary advances with these technologies to actually help physicians and other clinicians and even nurses to sift through the enormous and at times often repetitive amount of information and relieve them from excessive times spent documenting. It often appears that these technologies were made entirely for organizations, insurance companies, and so on, and not for the people who use it. And that now I'm getting back to Kevin. It's like we have to make them so that people can actually use them to facilitate all the other stuff that human beings are good at. Free up human beings to do the high touch. So the nurse assistant can actually have the time feeding a patient who has troubles with their oral intake, as opposed to spend a lot of time taking oximetry measurements, weighing patients, taking their blood pressure. Really, I see a world where high tech supports high touch. As we are studying in this world, physicians for visits. Am I cutting out again?
You cut out for a sec, a split second with that sentence, yes.
And give them the attention, and if enabled by AI, what Martin is going to provide, and saying, yeah, this patient, this person just had a variation. Now let's go and give them intensive nursing and medical attention. and enabled by AI, get a lot of precise information and treat them with precision medicine. That's the future that I envision. It's not about sticking a device on a person and the nurse assistants do their go away. That's not what it is at all. By the way, Ian Taylor, COVID experience in senior living facilities, and those would be not nursing homes, but still long-term care, have been a little bit more gentle because most people lived in single rooms or apartments, so the spread was not as intense. Thank you. Hope that wasn't too long. I could go
it was
on
excellent.
a lot longer, but that's the highlights.
No, I do appreciate it, and thank you so much for bringing in a couple
and
of
you
our
know what?
Q&As.
One thing that I wanted to mention also for Matthew Weeks and his anxiety about his parents, and I'm just talking about institutions as they are, but you all have probably heard of hospital at home, which is enabled by remote patient monitoring, and the overall trend in the industry is trying to get away from a larger institutional model to smaller models where more individual attention can be placed, and the medical care can potentially be augmented remotely.
That's excellent. And part of the Biden administration's nursing home reform report addressed that it's very important to establish a minimum nursing home staffing requirement. So the burnout, the shortages aren't going to be as detrimental as they have been in the past couple of years. And let me turn to Dr. Frasch with this question of really how new solutions can enhance healthcare delivery. How do you see AI fits into the picture? I mean, I know we talked about precision medicine and really providing that extra extra element of care to provide for these residents. How far are we away from being able to implement such AI-assisted technology, and how do you foresee being an adoption curve of difficulty?
Yeah, that's probably the key question. As I shared before, I feel that when we talk about AI, there's so much interpretation room, right? Everybody thinks about slightly different things. We're not talking about cyborgs or robots here. We're talking about a layer of software, artificial intelligence that reads the data that we get at a rate that's unprecedented so far, in not only in senior care, but in most actually aspects of the healthcare, and that uses algorithms that are based on our studies, and with our, I mean, not just our team, but actually a lot of teams who worked on algorithms to detect onset of sepsis, for example, or other forms of inflammatory response as a generic kind of thing that the body does when it sees a bacterium or it could be also a virus. So the detection of inflammatory response or sepsis as a goal is actually something where a lot of algorithms are already out there, but to connect the dots, to take these algorithms, take the devices that actually operate efficiently in a setting like the senior healthcare, the SNFs and so on. That's the challenge that we've been basically working on together, and I'm optimistic that we're actually really close. With that, I mean half a year to being able to say we can not only record continuously with biosensors such as Biostrap, MFIT, depending on what is ideal for the setting that we work in, but that we can also operate continually on the data with the algorithms that we already have, and anticipate change in a patient's individual, what we call basically something like a journey, a health basically journey that they experience. And I find it really exciting that the notion of the precision medicine really kicks in here, perhaps more than we've ever seen before, because we really are using this N of 1. As we just said before, I think it's a really important understanding to have. And we're asking, is there a change over time? But we're also using data from other patients in a similar setting or from a similar background, using also some information from the EMRs, from the health record of those patients, of course, if they allow us to do so. And so I think that a lot of work has already been actually done. A lot of understanding and algorithms are there. The technology is almost there. And again, as Kevin pointed out, it's not easy to go from an athlete to to somebody who is maybe 95 and has a lot of comorbidities and is in bed. But we are doing this work, and I think to connect these dots, hence also the name that we came up with, the Vitalink, is all about really linking the information and adding the artificial intelligence layer. To sum up, I think we're half a year to a year away from actually getting a serious AI on top of this, but what we already have is essentially simple form of AI, what we call a symbolic AI, that the physicians already use, but at a scale and at a frequency that only a machine can do. So I think we're really far ahead, and with the partnerships that we have and the experience, we should see deployments within extremely foreseeable futures. One of the questions here was about who is going to pay for this, and I think it's a really important question, because we want to make it accessible to everybody who needs it. And so this is part of the mandate that we and others here have to talk to Medicare, Medicaid, and to find ways to make it as accessible as we can, because I do think that all of us stand to benefit from such technologies in ways of decreasing the rehospitalizations and so on. So yeah, I'm excited. I think that the time could not be more high time for this to come to fruition in the next, I would say, really less than a year.
That's a beautiful timeline. And I mean, it would be amazing to see that happen in a year, especially with the increasing number of residents that will be requiring long-term care as our population ages. And Matthew Weeks brought up an interesting point, and I think maybe Kevin, you can tease out a little bit of what's coming with Biostrap. But he brought up that there's not yet an ICD-10 or procedure code for wearables like Biostrap that can provide reimbursement. So is there anything that we can say with regards to that matter, how wearable can be implemented, and potentially will it ever be reimbursed?
Yeah, I mean, more in the remote physiologic monitoring, which may be, post-hospitalization or a specialist monitoring their patient in a remote capacity. I don't believe it translates directly into long-term care facilities, but ultimately there are CPT codes established by the Center of Medicare and Medicaid Services, a total of about 5 of them, that do cover the device supply, the encounter time, which is defined as data aggregation and monitoring, as well as some forms of kind of synchronous and asynchronous communication. So it is reimbursed. There's hesitation out there right now, and that's largely around, was this a COVID thing, and is this here to stay? Very similar to telehealth. So today it is great. We can basically roll out remote physiologic monitoring. There's still pain points in terms of who's monitoring the data, right? You come to a health system and it's like, all right, we're going to bring this amazing software AI device to you, but we're going to add another job to you as well. And that's now monitoring continuous data. So if you weren't overwhelmed already, here you go. You're going to make some money off of it, but it's just not feasible. So luckily it is being paid for, but this, once again, leaning to the work that we're doing, and primarily Vitalink and his team here is, understanding the data so that we can actually decrease things like hospitalizations, right? Heart rate variability is one example. It's a very valuable but very non-specific metric, meaning we look at data and we see a downwards trend in heart rate variability. Generally, we understand that's probably not a good thing, but at what point does it actually make sense to intervene? At what point should we communicate with the patient, help them coordinate a visit with their specialty or their primary care doctor, save a life, save health outcomes, save the system money, as opposed to just driving in more visits that are unnecessary or overburdening the staff that's already overburdened. So once again, it all comes down to remote physiologic monitoring is reimbursed today by CMS and a lot of even commercial payers, but it's not quite prime time ready quite yet either. And I do think that it's here to stay. I think it's going to be reimbursed because it's been shown to decrease hospitalizations. And, some of the important metrics are, patient and provider relationships and stuff. People do feel more cared about when they're being remotely monitored and proactively intervened with. But once again, it's even coming down to retrofitting existing technology to meet a patient base, right? We'll not name anybody, but we're trying to take devices that were made for athletes and we're trying to now make them work for patients with COPD, right? It's construct validity is one thing, data reliability is another, form factor, all of these types of things. You need purpose-built technology, and this is something we're really proud of with Biostrap. We're pretty much pre-commercialization. We spent the last 5 years validating each one of our primary metrics because we foresaw this. We understand people should be remotely monitoring the data on their patients, proactively intervening proactively, but it only works if first the data has to be high quality, right? And then you got to work with really smart people like Martin to actually make sense of all of that data. But I'm sure he'll be the first to admit if the data is not accurate, the model's not going to work either. So it kind of goes hand in hand. So I think I probably answered your question like 10 minutes ago and kept going on. So I'll leave it there.
We're doing fantastic on time. So please elaborate as much as needed to really come to a conclusion and really make that point. And Matthew Weeks, you had one more question about FDA approval as a medical device as far as timeline. Stay tuned because we'll dive into that in just a little bit. Since we talked about money and estimates and cost, our next poll comes in quite the right time, I assume. So I would like to ask our audience just to, let's see, guess, or perhaps you may know exactly how much is being spent on long-term care in the United States annually, and that's excluding unpaid family caregiving. I'm very curious to see the answers coming in. So we've got majority answering 325 billion. Nobody's saying 195 billion. 275 billion is now tying, increasing. Okay, we'll give it a few more seconds, but the number is astonishing, and it's, to say the least, there's a lot of room for putting this money into the right places to provide the quality care that is necessary in this world right now. So we'd like to dive into the details of a recent study that Biostrap participated in, and was included in rather, and just dive into what we investigated, or per se, Martin, you were the principal investigator in this study. Just share some of the, what the purpose of the study was, what the study design was, and really how you investigated if wearables and under mattress sensors could be integrated successfully into skilled nursing facilities, and if they were at all well tolerated by patients. I mean, it's of course another element of adopting these wearable technologies. It's not only the provider, but is the patient willing to wear this device? Is it comfortable enough? So how did the study turn out, and what do you foresee this plays a huge role in, Dr. Frasch?
Yeah. No, thank you for the opportunity to talk about it. Yeah, we're very excited and thankful to Avalon and the partners that we have with MFIT and Biostrap for enabling us to ask the questions and go into the COVID units in the middle of the pandemic and approach the patients. The questions that we asked were actually really basic. Just like you said, we simply asked the first issue that nobody had an answer to: can we actually use the wearables or the biosensors that are put under the mattress in a setting like the COVID unit, which is already a new experience really to begin with? And can we use this technology in a way that actually helps us to identify the patients who are about to deteriorate, who might end up going to the long-term care after the COVID unit, or maybe even die from the virus? So what we did is we approached 2 sites in Washington State where we are, and we were able to recruit just under 24 patients into the study over a period of a quarter year. And the short answer is it's a yes. It is absolutely feasible to deploy the wearables like the wrist-worn device or the under-mattress sensor in such a setting. The staff has been extremely accommodating despite the worries and the stress that the setting already has as it is, especially when the vaccines were still out and there was a lot of uncertainty. So the staff has been extraordinary in enabling us to do the study, approach the patients, and the patients really went with it. And we felt that it's not just the athletes that appreciate the data, the insights. I think the patients understood that there was an opportunity here to pay, essentially to pay it forward. We understand that we were unable or intending to change the course of the treatment of the patients in the study. That's never the case in such a study, but they understood that they were able to help. And the acceptance was really good for the wrist-worn devices and for the sensors that go under the mattress. The approach that we took was intentional. The beauty of devices that we used, in my opinion, is that they're extremely complementary. There will be situations where under mattress sensor is ideal if it's a facility or a setting where you really just want to set it and forget it, but you will not be able to get information about the oxygen saturation. In a condition like a COVID unit, given that the staff is able to help enable it, a device that is able to get O2 SOD is really important, as we saw in the study. So that's really a complementary bit of information to our sensor under the mattress. The caveat is, of course, that it's a mobile thing, so it needs to be basically recharged. And as Kevin shared with us, this is not easy. And as you know, Apple Watch doesn't even go for a day. So there is a lot of work to do. And I'm extremely excited that I think we are doing this work together to change essentially the rules of the game here. Even though we needed to recharge the device that we used every day, we were able to set up a routine and a workflow with the staff to do so on a regular basis. So I would say that even with the limitation we have at the moment, it does enable us to collect the data on a regular basis in a continuous manner, in an unprecedented way that just did not exist before. We found that we saw specific changes in oxygen saturation fluctuation over time that are simply impossible to spot with intermittent checks, which is the standard of care now. And so that is really what opened our eyes to what appears to be what we already used the term, the silent hypoxia. It's a hallmark affecting potentially 1 in 5 to 1 in 2 of the patients with a COVID across ages, actually. And that I think there's a potential of technology like this to catch that. The insights from under the mattress sensors were also encouraging in ways that the sensors like these are able to, for example, measure the respiratory rate. And because they're essentially non-invasive in ways that they're just operating all the time, that information was also insightful to identify the patients who went on to the long-term care instead of going home. And so, of course, this is an early set of insights, and we are continuing to study this. But there is a promise here in settings such as these to detect the patients at risk of deterioration and to decrease the burden for the staff, importantly, as also Dr. von Preyss pointed out, to allow the staff to do the high touch and let the devices and AI do the routine and give us the new insights.
This is fantastic summary. And I just wanted to ask you to unfold the finding just a little bit. I was absolutely astonished by the profound result of the wrist-worn device. shameless plug, Biostrap was able to detect 9 times more data than spot checks. What does this mean? Does this mean higher safety? Does this mean higher accuracy? What was your reaction when you saw that data 9 times more of a detection of a dropped oxygen saturation?
This is as much a question to me as it is to Dr. von Preyss. So I'm happy to start, but I'm also happy to cede stage to Dr. von Preyss if you wish to take it on first.
Well, you know, I think the most important data we really got from the oxygen saturations, of course, that is a disease process, but that is very, very important. And I have to tell you, thanks to yours truly, we had implemented a very aggressive regimen of spot checks every 2 hours. That's just like for long-term care, that's unheard of. And we were faithful in doing it. I mean, Martin got all the data and there were thousands of spot checks done. But even so, when the spot checks, the manual spot checks and the wrist spot checks aligned time-wise, they were very close. So that's, there's a question here, can we trust wearable technology to fully replace manual spot check? I hope so, but I don't think we are there to do that yet. In this study, we did usual care, and so we did the every 2. So the results were very close, but in between those 2 hours, boy, did we see a lot of hypoxia clear up. So 9 times more hypoxic episode. And yeah, this was really, and that is a finding, I think that was the most important and astonishing one for us. And then the question, of course, is how do we make this data actionable? How do we integrate it into the existing platforms that we're using, the EHRs, which are, as I guess I have a little bit of a vendetta against EHRs. They are not that user-friendly. They're made by a bunch of software engineers, no offense, but they're not the ones that actually have to use them. And if any of you work on EHRs, just mark my words and maybe work on that. We would be so thankful. So how do we integrate them into the EHR? How do we make them visible? How do we avoid over-alarming? Those are 3 components that we are working on right now. But I think this was an astonishing finding, and together with the data now coming out that Martin mentioned, that there is silent hypoxia, it gets us into a completely potentially different space that is yet unexplored, that is asymptomatic disease detection. I don't actually know yet what to do with that. And I think that's something that further research will do for us. But that was the most important one. We had one patient where we had silent hypoxia or undetected hypoxia days before they clinically deteriorated to the point that this patient actually unfortunately passed away. But that was a huge time gap, really. And that is the opportunity. That's our opportunity right there.
And I'm going to come back to you in just a little bit as you being an early adopter of medtech into your facilities. But let me just, I saw a question in our chat. Dean Vasquez was wondering if this study is published. I believe it's in preprint. I'm not sure. Is it a link that we can share publicly?
Yeah. It's a public link, and let me make sure I do that. I appreciate it. And that's why we went for the option to post the preprint, because we wanted it to be accessible to all. So I'm just posting it here. So as you know, the preprint is not a peer-reviewed article yet, and it's obviously about to undergo peer review. We are still adding a few more interesting aspects, especially insights into the COVID impact up to 6 months after the unit. And so we're excited to add this in. And after that, we're going to submit for peer review.
Gotcha. Perfect. Okay, so I want to share the responses and results that come in from the poll about how much is being spent on long-term care in the United States annually. We had a tie between 325 billion and 275 billion. Now the answer is 275 billion. And let me just break it down what that means and who's paying. So according to the Pennsylvania Healthcare Association that did this analysis and published these statistics, 47% is Medicaid, 23% is Medicare, 23% is families out of pocket expenses, and about less than 4% by veterans and state programs, and less than 3% is private long-term care insurance. So obviously you can see majority of it is being paid by Medicaid and Medicare, and then families out of pocket expenses. All right, so thank you so much for participating, everybody, on these polls. It's really helping us, keep you engaged and interact and just give you some additional information about the topic. And before we wrap up, I have just a couple more questions, one for Kevin and Dr. Preyss. So Kevin, it seems that the wearable technology has the potential to improve operational efficiency, as Dr. Preyss and Dr. Frasch were talking about it, and patient outcomes through that passive continuous recordings. Can you expand on how that's possible and how biometric monitoring can play a role in this?
Yeah. From an operational standpoint, we've somewhat covered it, and that's, with limited staff, their time should be utilized at the top of their license. They should be providing the best care they can and not necessarily spending time collecting routine vitals that, generally maybe a layman shouldn't be doing, but digital technology can absolutely fill that gap. And this is really what we're working towards, our device today, ultimately towards FDA clearance, which is slated for the end of this year as well. So when you have the FDA clearance, you've done substantial equivalence testing. Can you trust the technology to do that? Absolutely, because the FDA would not clear a device that couldn't. And so that's an operational standpoint, just making sure the staff are providing care while things that can be automated are automated. Beyond that, in terms of patient outcomes, we've somewhat touched on that as well, and that's primarily through asymptomatic, or probably more often is pre-symptomatic detection. I am not a clinician, I'll be forthright about that, but it makes sense from a physiologic perspective that there would be physiologic changes that precede symptoms, right? You don't necessarily just have shortness of breath. You most likely have a slight increase in respiration and a decrease in your oxygen saturation. And this is the manifestation that ultimately leads to the symptom. We have done a lot of internal research with various universities specific to COVID-19, and we have seen approximately 1.7 days prior to symptom onset, biometric changes, predictable biometric changes in things like oxygen saturation, respiratory rate, resting or nocturnal heart rate, and as well as things like arterial elasticity, which is probably a little out of the scope of what we have 8 minutes for here. But essentially we have shown that you can detect physiologic changes prior to symptom onset. Back to what I had mentioned earlier, prevention is really the name of the game. Early warning, early detection is not usually thought of as prevention, but it absolutely is. If we can detect earlier, intervene earlier, we're preventing something more serious from happening. And this is really where I think, we can have the best impact on patient outcomes. And I personally don't think wearables are moving towards diagnostics. I think we are going to be amazing screening tools. It's very similar to COVID. Maybe we build this amazing early warning system and we can detect your likelihood of COVID. You still need to go get the confirmatory test, right? Because there's a lot of other behavioral factors and lifestyle factors that can affect data. It's not just respiratory illness that can cause an increase in your nocturnal resting heart rate. So can altitude and alcohol consumption. So essentially, it's a really good screening tool to prompt, intervention or perhaps confirmatory testing by the healthcare professional, which once again, definitely not our intention to replace by any means. It's simply about making them more efficient at doing their job more effectively. And so that's really how I see it all positioned.
Thank you so much for sharing this. And before we truly wrap, I have one more question to Dr. Preyss, and it correlates with what Matthew Weeks just brought up. Let me share his story to our audience. He sent us a interesting story in our Q&A. He was saying he put a pulse oximeter on his mom when she was hospitalized, and he would call the nursing station when it fell below relevant threshold. And as he was saying, it wasn't really well received by the staff, but even though at the end they were appreciative and thankful because they were able to intervene and adjust his mother's oxygen level more frequently, and she's fine now. Now that leads me to asking Dr. Preyss, how do you see, as an early adopter of medtech into your facilities, can you tell us how this was received from your providers and residents and what it really takes to improve overall adoption?
Well, as to the residents, thank you for that question. And that is the million-dollar question, really. It is,
Yes.
You can put all kinds of things on patients and develop algorithms, but if it's not used by the people who need to, or if it's not seen or used by the people who need to see or use it, what is it in the end for? So as far as usability, Martin already commented on that. Patients were really readily accepting the device. And I think there's an important psychological difference too. I have seen other remote patient monitoring approaches that use taped on the chest monitors or electrodes on the chest, which is really very different from a patient perspective. It's like, I am sick, I am in I'm in an institution, versus this is really, I'm being screened and monitored. And I think those devices probably have more of a hospital at home usability. As to the physicians and nurses, that is quite critical. What we don't want to see is what we are faced with in our everyday lives, another data dump into our labs. We can't deal with that. We have so many things going on all the time. So that is what we are researching right now. What is the best way to present these data?
Oh no, cut out for a second. Come back, Dr. Preyss, come on, come back. 3, 2,
same time, and really preventing for physicians and nurses to have to sift through the data and spending time that they don't have. So it's really not it's not really helpful. And I'm really fascinated by the story of Mr. Weeks. It sounds like you've had quite the experience, because really you were the human factor who actually watched these data, because they were already there. The nurses already had it, but they didn't have time to look at it. And what can we do with AI to replace you as the watcher of these data? Because that's really the key here, and that is what we're studying now, and that's why I think we're so thankful to have Martin with us, and who can help us with that. But in the end, it's really all about the nurses and physicians who should be able to use it. In this study that we did, was a feasibility study. The data were available, but they had to look into a website, and nobody had time to do that at that time. Nobody. And they were raw data, and we are going the next step now.
Indeed. Dr. Frasch, what's next? Any follow-up studies planned?
Yeah, we're, as Dr. von Preyss already alluded to, we're in the trenches, improving the user experience and the user interface for how we show the data to the provider. And one important aspect that many may be unaware of at first is that when we speak about RPM, we first think about the patient being at home. Here, the situation is actually the inverse. The patients are in a facility, but the physicians often are not. And that is just how things are. And so we have to work with this and help make a difference here by enabling the providers, wherever they may be, even if they have to oversee maybe not even a single site, but many sites, still have access to the patients when they need to see a change, and not, of course, being overwhelmed with a lot of information. So again, we cannot understate the importance of what we call in the jargon UX UI, so the user experience, user interface. It's always come back to this. It has to be informative and not overwhelming. And so we're extremely focusing on this together with everyone here on the panel. And with this in mind, we're excited to launch a project where we are going to not only look at patients with the COVID, but really explore as a test ride experience in a facility across the patients, whatever they may have, whysoever they may be there, and iteratively improve the user experience and the user interface, how we show the data. So that's currently the step we're at. And yeah, we're super excited to start.
This is brilliant. Thank you so much, all three of you, for taking the time. I think we've addressed a lot of questions, and I believe we were able to cover the Q&As, anything that's come through my few weeks. I really appreciate you for sharing so much of your experience and asking questions. And I think it's very, very timely to address these right now. So if anybody has any questions, ask now, or you're more than welcome to email us at Klaudia@biostrap.com, and I'll be happy to forward any questions to our panelists and get them answered for you. And thank you, Matthew. Big fan of yours. We love hearing that. Fantastic. All right. So thank you. Please have a wonderful rest of your day. And thank you so much for taking the time to join me in this conversation. And we will share this webinar on demand and share the link with everybody who may have missed it or want to rewatch it. Thank you so much.
Thank you for the opportunity.
Thank you, everyone.
Thank you, everyone.
Have a wonderful day.
Bye-bye.